All right, chapter 26, we're going to be talking about some soft tissue trauma. So, soft tissues, we got the skin, fatty tissues, muscles, blood vessels, connective tissues, membranes, glands, and nerves. Some of your soft tissues there, you can see where those blood vessels lay, where our bone is, that's a hard tissue, where our nerves is, and then all the way down to the organs. So, soft tissues, talking about the skin. Major functions is protection, water balance. We do some temperature regulation, excretion, and impact absorption. Okay. We have 3 layers of the skin, and this is they talk about this a lot on the test: epidermis, dermis, and the subcutaneous layers. Wounds often are classified as closed or open. Obviously, an open wound is something the skin is broken through. So there's the epidermis, it's the outer layer. The dermis is right beneath the epidermis, and the subcutaneous layer is the deepest layer there. That's where your nerves lie, your veins, and your arteries, right? So you got a good picture of that. You need to study that a little bit. Here we have a good little laceration on a hand. Closed wounds, internal injuries with no pathway from the outside to the injured side. So although skin unbroken may be extensively crushed, so this is where the skin is still intact, but there are internal injuries behind the skin. This can be minor to life-threatening, okay? So contusions, bruise, hematomas are similar to contusions. There's a lot more tissue damage. It involves larger blood vessels. You're going to see probably a larger bruise. Quite honestly. Closed crust injuries, you're going to have excessive force crushing or rupture internal organs, all right? Blast injuries, these can be very dangerous, can include open and closed wound types, potential for massive internal damage, and higher than with direct force trauma. Blast injuries can be extremely deadly, somebody's still talking to you, but they have a bunch of internal injuries that they aren't sure about. So here we've got an example of a contusion. It's that large bump there. Rupture of a hollow organ, so that could be a closed injury and that hollow organ's bleeding from the inside. An internal laceration or puncture. Here we have a isolated rib fracture that is then punctured what looks like the lung there. Closed injury with no open wound right there on a finger. Looks like you may have a fracture. And then an injury of a solid organ has bleeding there. So, patient assessment, bruising may be an indication of internal injury or internal bleeding. We've got to consider the mechanism of injury. Was the mechanism great enough to cause internal injuries? Crush injuries are difficult to identify. These can be pretty challenging. However, you might hear crepitus upon palpation if it's a bone, right? So we're going to take our BSI, we're going to manage our ABCs, and always manage if there's internal bleeding. Shock, we want to treat for shock on any patient we suspect possible internal bleeding, right? Any kind of internal injury. Splinting, we're going to split extremities that are painful, swollen, or deformed. We're going to stay alert for vomiting, continually monitor for changes of transport, apply cold pack to isolated injuries. Open wounds, we're going to talk about this a little bit. Abrasions, lacerations, penetrating trauma, punctures, avulsions, amputations. You need to know what these words mean for our test, okay? So open crush injuries, bite wounds, blast injuries, high pressure injection injuries, all those. So we should always have our BSI, standard precautions. If it's profusely bleeding, we might need a gown, that kind of thing. Just depends on what we're dealing with. Can an open injury affect the patient's airway or breathing? This is on your desk too. When can an open injury affect the patient's airway and breathing? Right? Anything to the chest, abdomen, or neck may require an occlusive dressing. Why is that? Because, right, those injuries can actually suck in air, okay? And so this is another test question. If a patient has an opening into their arm where there's veins running through, and or in the neck, anywhere where, let me start over. In an area where there's veins like the neck, if those veins have kind of negative pressure, if you've ever had any kind of, done a siphoning effect with a garden hose or siphoned gas out of a gas tank, you know what negative pressure is. The veins have that same system. okay? So if air is able to get into the veins, it can actually draw air, which can be extremely dangerous for the patient. So make sure we're getting an occlusive dressing on any neck, chest, or abdomen injuries. We need to get an occlusive dressing on there to stop that, okay? Stop that air entry. Lungs can collapse. We can have tension pneumothoraxes in the lungs if air is drawn into that chest cavity. So we have to watch for that and be very careful. Got to use gloves, gown, protective eyewear. That's why we wear eyewear on every call here, or at least we're supposed to. So patient care, we're going to expose the wound. We're going to clean the surface of the wound, control bleeding. For all serious wounds, we're going to provide care for shock, administer oxygen, prevent further contamination. We're going to bandage dressings in place after bleeding is controlled, keep the patient lying still, reassure the patient. So specific types of wounds, okay? Abrasions and lacerations, we're trying to limit wound contamination. In abrasions, we're talking about, scuffs, that kind of thing. Lacerations, cuts. Hold direct pressure to control bleeding. Always check pulse, motor, sensory function. Okay? Penetrating trauma. We got to use caution as objects may be embedded deep. There may be glass way down in there. So we're going to check for exit wounds. They may require immediate care. Bullets can fracture bones as they enter. So there could be a lot of internal injuries along with those external wounds. Stab wounds are considered serious if they're in a vital body area. So if they're in the thigh and they don't seem to be bleeding majorly, probably not a serious injury. But it could be if it hits that femoral artery, right? So we're going to reassure the patient, search for exit wounds, assess need for BLS, basic life support, and we're going to follow our local protocols if we need spinal immobilization, transport the patient. For National Registry, just spinal immobilize them. Once you're off the National Registry, we can go from there. So bullets can travel in unpredictable paths, so we need to check for exit wounds, not just in a straight line, but all over. So if you have a side entry wound with a person shot, or you notice a big hole in the front of the chest, you can't just look at the back of the chest. You have to do a circumferential look, okay? And look for that exit wound. Look for any other signs of other holes, and whether or not they're entrance or exit wounds it's not as important as long as you're doing a good, thorough check. Okay? So here's a gunshot wound to the right flank. I was hoping it was going to show an exit wound, but it does not. So treating impaled objects, do not remove objects. It may cause severe bleeding. That knife that may be stuck into them may be holding pressure on an artery, okay? You yank it out, and you're not obviously a surgeon in the field, you're not going to be able to fix that problem. So don't go removing knives, okay, or impaled objects. We leave them in place. If they're impaled on a fence, we're going to cut that fence and take the whole section of fence with us to the hospital. So, treating impaled objects. We're going to expose the wound area, control profuse bleeding by direct pressure, apply several layers of bulky dressing, secure dressings in place. Care for shock. We maybe use hemostatic dressings to try to get that bleeding to stop. We're going to provide rapid transport. Here's an impaled object, and they're going to put a bulky dressing around it to secure it in place, okay? Because we don't go yanking it out. We secure it in place. So I've used those, they look like they got some 8x10s on either side, and I've used some real bulky Kerlix to wrap that around there, keep it in place, try to, there it is. There it is. So, it's exactly what I would do. Object impaled in the cheek. Take care the object does not enter oral cavity, causing airway obstruction. If the cheek wall is perforated, profuse bleeding into the mouth and throat can cause nausea and vomiting. We've got to monitor that bleeding, use suction, appropriately position the patient to avoid causing airway compromise. So if they're alert, they may need to be leaned forward so that they don't start aspirating blood. External wound care will not stop the flow of blood into the mouth. We're going to examine the wound site both inside and out. If you find the perforation and can see both ends, go ahead and remove it. This is one of the few times when we remove something, if you can see it on both sides, and it's not like jammed in there, if it can be easily removed, do it. There's a pencil. Good gosh, that's not fun. So the process of removing an impaled object from the cheek. Looks like they're going to slowly, I'd probably leave that in place as long as it's not causing problems. If it's causing a lot of problems, they're going to slowly pull that out. Or position patient to allow for drainage, monitor patient's airway, dress outside of the wound, provide oxygen, and care for shock. Puncture wound or object impaled in the eye. We're going to stabilize the object, apply rigid protection, have another rescuer stabilize dressing and cut while you secure them in place with self-adherent roll bandage or with wrapping of gauze. Okay? So that's one way to do it. Cups are another idea, like little plastic cups. Cut out the object, put the cup around it, secure the cup with lots of tape. And then we're going to cover the other eye as well so that they aren't trying to look around and move the eye. So we're going to consider need for oxygen and care for shock, reassure the patient, provide emotional support. Avulsion. So what's an avulsion, first of all? You got to know what an avulsion is for your test, all right? So we're going to clean the wound surface, fold skin back into it's a flap the skin off, in case you don't know. You need to look it up so you have the actual definition. Fold skin back into the normal position, control bleeding and dress with bulky dressings. If avulsed parts are completely torn away, save in a sterile dressing, keep moist with sterile saline. That is a test question. What to do with a portion that's completely torn away? Sterile dressing, keep moist with sterile saline. Take steps to control hemorrhage immediately. Apply direct pressure to control bleeding. Use tourniquet only if all other methods fail. Caring for an amputated part, okay? They're going to put it in a sterile dressing, and then they're going to put it on ice, okay? A dry sterile dressing, and then on ice. Oh, sorry. Sterile saline soaked gauze. Sterile saline soaked gauze, and then put it on ice. My apologies. Don't put it directly on ice. Put it sterile saline soaked, and then put it on ice. Wrap amputated part in sterile dressing and secure dressing with self-adhesive gauze bandage. Wrap or bag amputated part in plastic bag. Keep it cool with a cold pack or ice. Do not immerse amputated part directly in water or saline. Genital injuries. Control bleeding. Preserve avulsed parts. Consider if injury suggests another possibly more serious injury. Display calm professional manner. Dress and bandage wound. Consider possibility of sexual assault. So what you should not do is be like, oh bro, oh my gosh, oh man, that looks so bad. Don't do that, okay? Stay calm, be a professional. These folks need your support, okay? They're in a bad way and they need you to be a professional caregiver. Burns. Okay, what did I tell you? Like 10% of this test is over burns, right? So it may involve more than just skin level structures. If respiratory structures are affected, swelling may occur, cause life-threatening obstruction. Do not let the burn distract from spinal damage or fractures. So we got to classify the burn, agent and source, depth, severity. Okay? So what chemicals, what caused it? Chemicals, electricity, what? Report the agent, when practical, the source of the agent. Never assume the agent or source of the burn. Gather as much information as you can from bystanders, all that good stuff. So, burns are classified by depth, right? This is part of your test question, what each one of these are, right? So superficial, okay? Partial thickness and full thickness. All right, how deep is the burn? Superficial burn, first degree, involves only epidermis, reddening with minor swelling. Partial thickness burn, second degree, epidermis burned through, dermis damage. Deep intense pain, noticeable reddening, blisters and mottling. Full thickness burn, third degree, all layers of the skin are burned, blackened areas surrounded by dry white patches. So what do you think that is? Superficial, right? Sunburn, superficial burn. Partial thickness burn, okay? Looks like maybe some scalding water, I'm not sure. Another partial thickness burn, a little bit worse. See that blistering? Full thickness burns, okay? All the way down. Yeah, that's nasty. So determining the severity of the burns, we got to consider the agent or source, what regions of the body are burned, the depth of the burn, what extent the burn has done, like how much of the body, age of the patient, other illnesses and injuries that may be affected. The rule of nines is a way to determine the extent, right? Helps estimate the extent of the burn area. The adult body is divided into 11 main areas. Each represents 9% of the body surface. It's going to give you, the test is going to give you areas of the body and ask you to calculate body surface area burned using the rule of nines. Okay? There it is. You need to study this. You need to understand the rule of nines as it relates to adults, children, and infants. Okay? So the back of the leg is 9, the front of the leg is 9. Okay? Abdomen is 9, chest is 9. Back of the torso, back of the chest. 4.5 for the front of the arm, 4.5 for the back of the arm, right? 9 for the entire head. So if you add all that up, 1 for the genitals, you're going to get to 100%. Okay? Must be classified to determine order and type of care, order of transport, maximum information provided to the ED. We need to know as much as we can about the burn to be able to give that information to the burn center we're going to. So a moderate burn in a young adult can be fatal to a geriatric and or a pediatric. Okay? And why is that? So obviously geriatrics probably have other comorbidities, other things going on, other medical problems. Infants and children have a much greater relationship of body surface area to total body size, resulting in greater fluid and heat loss from burned skin, right? So there are small bodies with a lot of body surface area. So if their body surface area gets burned, it's going to affect their small bodies, where adults have a large body surface area, but they have a larger body to compensate, larger body size. Okay, and that may be a test question as well. So, patient care for thermal burns. Stop the burning process and cool the burned area. Ensure open airway and assess breathing. Okay, so any patient with circumferential neck burns, we're going to worry about the airway. We're going to monitor that airway very closely. We're going to be ready for that airway to crash. Okay, any kind of facial burns or charring, we're going to be watching that airway very closely. May or may not be a question on the test. So we're going to look for signs of airway injury, complete primary assessment, and treat for shock. Evaluate the burns by depth, extent, and severity. Do not clear debris. You should remove clothes and jewelry. We're going to wrap with dry, sterile dressing. For burns to the hands or feet, remove patient rings or jewelry and separate fingers or toes with sterile gauze pads. Patient care for chemical burns. We're going to wash away chemical with copious amounts of water. If it's dry chemical, we're going to brush it away first, and then we're going to flush it with copious amounts of water. Be careful when you're brushing dry powders. You need an N95 mask on. Your patient needs an N95 mask on. Think about if you ever get that into the air and then breathe that in. For yourself or your patient, it's going to be bad. Then we're going to wash it with copious amounts of water. Okay? Chemical burns, we're going to move contaminated clothing, apply sterile dressing, and treat for shock and transport. Radiological burns. Exposure to high levels of radiation can harm the human body both immediately and in a delayed fashion. Great number of sources of radiation. It's difficult to detect without specific monitoring equipment. This can be extremely harmful. We don't want to approach a radiological injury without protective equipment and specialized training. Patient with a radiological burn only after the patient has been decontaminated. So we need a hazmat team to decontaminate the patient, and they're going to present with thermal injuries. Electrical injuries, severe damage to the body by disrupting nerve pathways. There's an entry and exit. Burns are very possible. Can cause respiratory or cardiac arrest. Bones may fracture from violent muscle contractions. We're going to provide airway and breathing care, provide basic cardiac life support, be ready to defibrillate, care for shock, and administer high concentration oxygen. Care for spinal and head injuries as well as extremity. Evaluate burn sites, cool burning areas, and smoldering clothing the same you would for a flame burn. Apply sterile dressings and transport ASAP. Okay? It is important to remember with an electrical burn that these patients may have more hidden injuries than you know about. Okay? So don't assume that you just have a small burn and that's it. They may have major hidden injuries that we don't know about. Alright, dressing. Any material applied to the wound to control bleeding and prevent contamination. Bandage is any material used to hold the dressing in place. So there's a dressing and bandage. Universal dressing is available for profuse bleeding for a large wound. Pressure dressing is used to control bleeding. Pressure dressing has a large dressing on it, and then it has a tight constricting dressing over top of that. Occlusive dressing is used to form an airtight seal. Wounds to the abdomen, large neck, veins, open wounds to the chest. We talked about that. Okay, bandages hold the dressing in place. So we put a dressing on a pressure dressing. We're going to put it on a dressing, and we're going to have a tight bandage to hold it in place. So dressing open wounds, we need BSI. We're going to expose the wound, use sterile or very clean materials, cover the entire wound, control bleeding by direct pressure and or hemostatic agents, or dressings to stop or slow the bleeding, and do not remove dressings. So if you had a test question about what to do on something that was bleeding through. It says you've applied direct pressure and the patient's whatever is continuing to bleed through. The answer probably, if the next answer was remove the dressing and apply more, would that be the right answer? Probably not, right? Because we never remove bandages. So if it was like, remove the dressing and do X, or remove the dressing and put on a tourniquet. No, 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 no. That is a test question trying to lead you the wrong answer. But if your answer was, continue to apply pressure and apply a tourniquet, okay, that's the right answer because we don't remove the dressing. Small factors change us on these test questions from the right answer to the wrong answer. And it's not JCAT trying to be mean to you or any other agency. It is the way the National Registry test questions are. So understand that the answers can lead you the wrong way very easily, and that you need to make sure if the answer is not something that the test question is talking about, you stick to answers that focus on what the test question is talking about. They may be the right answer for a completely different situation. Don't let the answers, the wrong answers, drive you to that way because they're talking about the correct treatment for another problem. Focus on the problem and the question and answer that. Sounds like common sense until you're in there taking these test questions and they're driving you to wrong answers. We're going to bandage open wounds. You can apply a self-adhering roller bandage. So Coban, we love Coban. This is not Coban though, this is Kerlix. Coban works great. If you need to, when you go on your clinicals, have somebody show you Coban. It's the best thing ever. I use Coban to fix my car. Coban is just wonderful. So, soft tissue injuries may be closed, internal with no pathway to the outside, or open where the skin is interrupted. Closed injuries include contusions, which are bruises, hematomas, crush injuries, and blast injuries. Open wounds include abrasions, lacerations, punctures, avulsions, amputations, crush injuries, and blast injuries. For open wounds, we're going to expose the wound and control bleeding. For both open and closed injuries, we're going to take BSI, note mechanism, protect the ABCs, treat for shock and transport. Burn severity, you need to know your rule of palms, you need to know your rule of nines, how to calculate those appropriately, what type of burn they are, trying to figure all that out so we can get that to the ER. How to treat these burns, pretty much all dry dressings. You need to know how to treat avulsions and amputations for sure. All right, that's pretty much it for chapter 26. Okay? Remember exit wounds on any kind of entrance wound. Anything where there's an entrance wound, look for an exit wound. And remember, it's maybe not a straight line. It may have come in here and gone out your side. It's hard to tell. So we don't know what it hit in there, especially smaller caliber weapons. 22s are known for getting in somebody and just bouncing around. May not ever come out, or it may come out a completely different direction. They don't have enough velocity to go through and through. They hit stuff and they move. So just be aware of that. And that's it for chapter 26.